call to this webinar. Before we proceed, I would like to recite the IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. Be the healing cure beyond greed and lure. I welcome everybody to this webinar, which is the second in the series of PG Pathshala that is organized under the aegis of IMA KSP and WDW subcommittee of IMA KSP. I welcome Dr. Srinivas sir. I welcome the president, Lakkol sir, and Dr. Srinivas sir, and also all the people who have joined us for this webinar. I would request our president, Dr. Lakkol sir, to please say a few words before we start with the webinar.
Yeah. So can you hear me, madam?
Yes, sir. Yes.
Good evening to all. Today we have got a very good session, the series of webinars, that is PG Pathshala. Dr. Srinivas,
yes, sir.
President-elect of the Karnataka State Branch, and our Secretary, Karnakaran, and Treasurer, Vijay Sarathi, and also Chairperson of Women Doctors Wing, Manpreet Kaur. And we have got a very good renowned persons. Today, we have got a mixed bag topic. The topic itself shows how many renowned speakers are there, chaired by a very important Dr. S.S. Kalan Shettar, who is a professor and head of the Department of Pediatrics, BLDUs, Sri B.M. Patil, Vijayapura. Really, we are fortunate to have me as a chairperson. Welcome, sir. And very different topics are there. As you all know, our Dr. S. Srinivas, President-elect, is one of the well-known pediatrician of our IMA KSV. He is also President-elect. He is also with us. Today's important topics, Dr. Tirumala Kulkarni is going to speak on short status evolutions, and Dr. J. Prakash, recognition and evolution of sick child, and Dr. Shishal Gidaganti is going to speak on neonatal screening. So all the three different topics are very, very unique one. It will help to the PG students, and we request all the PG students to join more and more numbers. Make use of it, the series of webinars, and that will be helpful in your profession, in your curriculum. So with this forward, I don't want to take much of time because our speakers are also waiting for the students to hear the very important topics. And I hand over the mic to Manpreet Kaur, Chairperson of Women Doctors Wing. Over to you, madam.
Thank you so much. Thank you so much, sir, for those encouraging words, sir. Before we start, I think just 2 minutes, can I please request Dr. Srinivas, sir, our President-elect, also to say a few words?
Yes, sir. Good evening to everyone. Our President, Lakkol sir, Manpreet Kaur madam, everybody is doing wonderful work. And I am very much happy to be here today. And definitely you are delivering very good talk, especially this one. Definitely we'll wait for that. And all our PGs also, they're joining. So definitely today, very wonderful job. I thank even our Secretary Karnakar also, I think he is there. And everyone I'll thank, and I'll appreciate our speakers. And definitely without taking much time, I'll ask our speaker to start, madam. Thank you, Varandal, madam. Yeah.
Thank you so much, sir, for those words. I would like to now call upon Dr. S.S. Kalan Shettar, sir, the chairperson for this session. John, can I please have sir's CV? John?
Yeah.
Can I have sir's CV, please?
Yeah. The internet here is little fluctuating.
Okay.
You have a copy?
Dr. Kalyan Chittor sir actually need not have any introduction because he is so well known in the pediatric circles of
Network from
our country. But still, even though it's a formality, it would be an honor to introduce sir if I get his CV on the screen. If not, then I have worked with Dr. Kalyan Chittor sir as a obstetrician since I think now almost 20 years. And whenever, otherwise, I think logisticians always feel that when we send a baby to you, we get a little worried that baby, is it going to come back to us soon? Before I get into that, let me introduce sir first. Sir is MBBS from Alamein Medical College, Bijapur in 1997 and MD Pediatrics from Dr. VM Medical College, Sholapur in 2004. He ranked first in the Shivaji University in his MD exams. He is presently working as professor and head of Department of Pediatrics in BLD Universities, Sri PM Patil Medical College and Research Center. Sir has a teaching experience of 16 years. He has more than 20 published papers in national and international journals. He has guided more than 10 PG students. He's given talks in various national and state conferences, and his special interests are intensive care, nutrition, and infectious diseases. Over to you, sir.
Thank you, ma'am. Thank you for the kind introduction. At the outset, I would like to thank IMA KSB and the Women Doctors Wing of IMA for giving us the opportunity to present a few talks to in the PG Pathshala. The topics which have been selected are very important for exam-oriented PG preparation and all. So without wasting much time, I would like to first call upon our first speaker, Dr. Trimal Kulkarni. He'll be talking on the short stature evaluation. Over to Dr. Trimal Kulkarni, sir.
Sir, can I request you to introduce Dr. Trimal Kulkarni, sir? John, do you have the CV?
Yes, ma'am. I shared.
Yeah, ma'am. Dr. Trimal Kulkarni is right now working as assistant professor in the Department of Pediatrics in the BLD Wdw BM Patil Medical College. He's been a very good academician. Right, he has worked as organizing secretary of CME on COVID-19 during the COVID pandemic. He has worked as faculty speaker in the international CME on COVID-19 organized by BLD. He has given talks as a guest speaker in the national webinar on preterm birth syndrome, which was organized by OBG department of BLD. He has contributed as an author and co-author in more than 10 publications in national and international journals. He has attended various workshops like basic NRP, simulation workshop, critical care management, and research methodologies. He has been an active member, life member of IAP and NNF Karnataka. And notably, he is member of Royal College of Pediatrics and Child Health. He's been a very keen interest. He takes very keen interest in teaching pediatrics, especially to our PGs and all. And he has selected a topic on the short stature evaluation. Over to Dr. Trimal Kulkarni, sir.
Thank you, sir. It was honor to get introduced from my role model. So without wasting much time, I think I should start the topic for which we are here. So today's topic is short stature evaluation. To define short stature, we take it as height below third centile or less than 2 standard deviations below the median height for that age and sex according to the population standard. But there are some exceptions to the rules always. So what else can be considered as pathological short stature? If the mid-parental height is less than 2 standard deviations, then the target height, or if the height velocity is crossing 2 centiles downward on a growth curve, or it lies persistently less than 25th centile, then also we'll have to evaluate it as short stature. Shortly on factors of controlling the height. For this, we know there is an ICP model, infant, childhood, and puberty. During infancy, from birth to infancy, the nutritional factors and thyroid hormone control the height. After 2 to 8 years, it is predominantly growth hormone. And during puberty, gonadotropins and thyroid hormones contribute for increasing the height. If we have to evaluate, definitely we have to consider a detailed history, a careful examination, and laboratory evaluation comes next. So more focusing, today's focus is on evaluation. So I would like to keep the history part and the laboratory evaluation later on. If a child comes to any of us, like if I consider myself sitting as a resident in the pediatric OPD, and if I see a short child, what I should assess in the child? The assessment begins with accurate height measurement. If it is below 2 years, with an infantometer or a stadiometer as shown in the pic. Secondly, what we do is we compare the child's own potential by calculating the mid-parental height. For boys and girls, the formula is little different. It's as on the screen. And then we calculate the target height by adding or subtracting 6 centimeters. Previously, this was 8 centimeters. That's why I have put it in bold. And then comes the most important thing. What we do is we see the height velocity. What is the rate of increase of height in over a period of time? Because this defines whether this short stature is a physiological variant or it is going to be a pathological cause for short stature. So this is very important step. And then we plot this height velocity on a height velocity curve. So how do we calculate height velocity? Suppose if we see a child at 5 years is 100 centimeters. And if he comes back to you at 7 years and he is 110 centimeters. So simply it will be like in 2 years, he has grown 10 centimeters. So the height velocity will be 5 centimeters per year. It's as simple as that. Now once, if you know the normal height velocity parameters, it is easy. So I have put in this slide. Otherwise, you can calculate by the difference in the height when you see the child. At least you need to calculate for 6 months. If you calculate for every month, it won't be properly that won't be a proper evaluation. So this is the height velocity curve. The important thing here is the curves are different for boys and girls. Secondly, the third centile is not the pathological thing. If the height velocity is below 25th centile, you have to denote it as short stature. This is available in Indian Pediatrics 2019 January issue. You can take this from Indian Pediatrics. Suppose if in case you don't have height velocity curves in OPD, then there is a broadly you can take it in below 4 years if the height velocity is less than 5.5 centimeter per year, or above 4 years till 6 years if it is less than 5 centimeter per year, it is called as pathological. And above 6 years in boys, if it is less than 4 centimeter per year, in girls if it is less than 4.5 centimeter per year, it can be taken as pathological. So if the height velocity is normal but the child is short, what you need to rule out importantly is it can be either familial short stature or constitutional delay in growth and puberty. And most often we see that these are the causes, and unnecessarily the child gets evaluated more. One more important step is pubertal assessment and bone age. So pubertal assessment is done by SMR staging. I won't go into the details. Everyone can see those in every book. It is available. But the importance is there will be precocious puberty or delayed puberty. So precocious puberty could be in stages of hypothyroidism, hyperestrogenic states, or hyperandrogenic conditions. And delayed puberty will be there in constitutional delay in growth and puberty. I'm running through these slides because SMR staging, all of you know. Now comes the important aspect of evaluation of short stature. Conventionally, what we do is, after following these initial 4 steps, we go to assess what is the bone age. So bone age is conventionally calculated by taking the X-ray of the left hand, and then we go through an atlas over here. Otherwise, there are broadly followed methods are by Tanner-Whitehouse method or Grulich-Pyle atlas. Nowadays, even there are many softwares coming up like Bone Expert or MediClass app, wherein you can put in the things which are asked and just you can get the bone age. Now, suppose if you don't have this, I mean, you can calculate it from atlas. It is very easy. But when you should consider the bone age to be significantly delayed, that is very important. So roughly, when there is a difference of 20% between a bone age and chronological age, it should be considered significant. And the formula which is taken like Karpel-Boles -1, which we used to do, should not be followed. The other rule of thumbs are like more than 1 year difference in bone age and chronological age if the child is 2 to 4 years old, or if the difference is more than 1.5 years in bone age and chronological age when the child is 4 to 12 years old, and more than 2 years of difference about 12 years of old. This will be considered as significant delay in bone age. Why do we need to know all these ages? Chronological age, then bone age, height age, weight age. Because these are the things we are going to plot on the growth chart. And then we can arrive at a logical etiological cause for short stature. So if we consider the physiological variance, like familial short stature, here the bone age will be equal to the chronological age. Whereas in constitutional delay in growth and puberty, bone age will be slightly delayed than the chronological age. Whereas in case of malnutrition or chronic diseases, what we see is chronological age will be more than height age and it will be more than weight age. And there will be mild retardation of bone age. Here you can see. Whereas in case of precocious puberty, the bone age will be advanced and the height age will be more than weight age. Weight age will be more than the chronological age. This gets altered in endocrine diseases, wherein the chronological age will be more than the weight age and weight age will be more than height age. And the bone age will be grossly retarded. So these are some of the basic things we should know before we plot these things on growth chart. Now coming to the important day aspects, I mean the causes which we find day in and day out. These are most oftenly the familial short stature or the constitutional delay in growth and puberty. So this is a growth chart. Suppose, for example, what we'll take, the child is 5 years old. So if he is below this 3rd centile, we'll say that he is having short stature and he needs evaluation. Then what we will do is we will calculate the mid-parental height. And suppose, where is the mid-parental height labeled, we have to plot it at 18 years. So if it is around 160, this is the mid-penetral height. What we have to do is add either 6 centimeters or deduct 6 centimeters from this. So if you add 6, it will go up to 160. I went little higher or downwards this. And what you need to do is draw a centile parallel to this, joining these 2 points. We need to have certain drawing skills also. So if it is going like this and it's still below 3rd centile, and now what we have to do is calculate the bone age of this child. So bone age, what is the bone age? Bone is nothing but when the X-ray is done, we have to compare it with an atlas and come to a logical age according to the X-ray. And if suppose the bone age is showing that the age of this child is 4 years, so the bone age is somewhere around here. So what will be our conclusion is this might be constitutional delay in growth and puberty, since the bone age is less than the chronological age. But if it was coinciding with the chronological age, then it will be familial short stature. I think, hope you are understanding. These are just for the comparisons. Now, if this is not followed, this is not a physiological variant, what is the next step we do is we calculate the body proportions. So according to this, we have to calculate the upper segment and lower segment ratio, which according to Western data is at birth 1.7, at 3 years 1.3, at 7 years 1, and then onwards 0.9:1. But Indian Journal of Pediatrics, June 20, 2019, we have got the Indian standards, wherein the upper segment, lower segment ratio is 1.45 at birth, 1.35 at 3 years, 1.12 at 7, and it crosses 1 at 7 years in boys. In girls, 1.44 at birth, 1.35 at 3 years, at 7 it is 1.13, and it crosses 1 at 6 to 7 years. So once you calculate this, if you have increased US by LS ratio, the conditions could be rickets, achondroplasia, untreated hypothyroidism. Or if it is a disproportionate short stature, or the US by LS ratio is decreased, then what we see is the other causes like spondyloepiphyseal dysplasias or vertebral anomalies can be seen. Another quick note which we should have about these proportionate and disproportionate short stature causes is proportionate short statures can be seen in chronic disorders and endocrine causes. But how to differentiate in these two causes is weight for height will be reduced in cases of chronic disorders, whereas in case of endocrine causes, the weight for height will be either normal or increased. So this is one important addition you have to remember. A flow chart here will simplify the things. Short stature first, then you have to see if there is some obvious dysmorphism. Then the causes could be Russell-Viper, other syndromes like Russell-Silver, Noonan's, Turner's, Down syndrome, and a couple of others. If it is there are no dysmorphic features and the child appears to be normal, then you have to say first find out whether it is proportionate or disproportionate short stature. The proportionate short stature, as we have already discussed, constitutional delay, familial cause, systemic illnesses, and endocrine causes. Systemic illnesses will have weight for height will be reduced. Endocrine causes, weight for height will be either normal or increased. Then comes the disproportionate part. Here we have to do whether it is a short-limbed dwarfism or a short trunk dwarf. And once we come to that, then we can come to a logical conclusion for whether what could be the exact condition. Because short trunk dwarfism will be seen in some metabolic complications or storage disorders like MPS, and short limb dwarfism can be seen in achondroplasia and rickets. So these are some of the causes of pathological short stature. How do we come to each of these? We have already seen that approach. Just a quick word about growth charts. Growth charts are several types, as you can see on the screen. I can't read the whole thing, but below 5 years, we prefer to use WHO growth charts, and above 5 years, we are preferably using the IAP modified growth charts. Ideal ones are prescriptive. These are the WHO growth charts. For boys, it is blue. For girls, it is pink. These are the IAP growth charts, which were followed. I mean, they were designed in 2015. These are for boys. And these are the newest ones, the pediatrician-friendly growth charts. These are being followed since 2021. Here, the additional element is you have a MPH calculator here in itself. So all you need to know is father's height on one side, mother's height on the another side. You have to join these two. Suppose you join. Suppose father's height is 168 and yeah. Sorry for this technical problem. Yeah. Now the father's height here is suppose 167 and mother's height is 154. Okay. So if we join these 2 points, it is lying on 25th centile. So anything above this will be not be denoted as short stature. Okay. You can calculate and see plot, but this has been done for busy pediatricians for office practice, and these are relatively easy. Now, to complete our diagnosis and evaluation, what we need to do is we have to take a complete history. So these are the points which are history-wise important, and they point towards a specific etiological cause. Then you have to have some pointers to etiology of short stature. Like we have midline defects or micropenis, frontal bossing. Then it points towards growth hormone deficiency. If there is rickets, we have to evaluate for renal failure, renal tubular acidosis, or malabsorption syndromes. Pallor will be a clue towards renal failure or again malabsorption and nutritional anemia. So these are some of the important points. And what we need to pick up from examination is whether it is dysmorphic child or it is a disproportionate child, or if there is some hypertension. These are things which will, could be said as telltale signs. It will tell you the story and pick up the etiology upfront. So don't miss these clues from the examination. Just to complete the list, we have to have investigations. Once we are clinically done, what we have to do is prove it on investigation. So there are 3 levels of investigations. These are to be followed. One is with complete hemogram, with ESR, bone age, urine analysis, stool, then RFTs, LFTs, serum calcium phosphorus and alkaline phosphatase level, ABG, and fasting sugar levels. bone age is in level 1. Then if you don't find anything from this, go to level 2 and investigate for serum thyroxine, TSH, karyotype to rule out Turner syndrome in girls. If the above investigations are normal, observe height velocity for 6 to 12 months, or if it is going below third standard deviations, then go for level 3 investigations, which are celiac serology, growth hormone stimulation, and MRI brain. This is again a flow chart, but we can skip this. So management involves definitely an endocrinological reference, counseling of the parents, dietary advice. This all depends upon the etiological cause, the rest of the treatment, along with the specific management. So monitoring is important. Lastly, these are the steps which I have already discussed. Some of my references. Thank you.
It was a nice presentation by Dr. Trimal Kulkarni. Our next speaker will be Dr. Prakash.
Sir, it is echoing, sir. I think there are 2 devices at the same.
Yeah, we are working on it.
Yeah.
Our next speaker is Dr. Jay Prakash. He's a pediatric intensivist working as assistant professor in our BLD Medical College. He has done MBBS from BLD Medical College, DCH DNB from Chennai, and he has done a fellowship in pediatric intensive care from Bangalore, St. John's Medical College, Bangalore. He has got publications in index journals. His special interest is point of care ultrasound application in PICU, which is helping us a lot in managing sick children. He specializes in pediatric neurocritical care, and it's notable that 2 of his studies got awarded in pediatric state pedicriticon. So over to Dr. Jay Prakash. He'll be presenting a topic on sick child evaluation, recognition and evaluation.
Good evening to all.
Yes, sir. Okay, you are audible, sir.
Yes. Thank you, sir, for your kind introduction. And first of all, I want to extend my thanks for IMA KSB Women Doctors Wing, who invited us as speakers. And Manpreet Madam is our teacher. So very delighted to present my talk in front of her. And I thank one and all. So let me begin my talk. So I am discussing.
Nice to see my student as a speaker, sir.
Thank you
Thank you for accepting the invite.
Yes, ma'am. Let me begin. Today I am discussing about identification and evaluation of sick child. So I am going to discuss in these headings: introduction, steps of evaluation, initial assessment, what is primary assessment, what is secondary assessment, and what diagnostic test can be done. Madam, am I audible, sir?
Yes, sir. You are audible.
You're audible.
Yes, ma'am. Thank you for acknowledgement. So whenever a child comes to emergency room or whenever a child comes to PICU, it will be encountered many a times by the residents who are there at the casualty or emergency room or in the PICU. So they will not be knowing exactly what can be done when a child comes to when they encounter a sick child or non-sick child, whatever. So for that, we need to have a structured approach where they can differentiate a sick child from the non-sick child and life-threatening condition from the non-life-threatening condition, so that the case management differs in a sick child and non-sick child. The sick child will get the immediate care, which will revert back the deranged physiological process to the normal physiological process, and the recovery can be very fast. So the thing is, whenever any sepsis or whenever any trauma, infections, anything happens for a child, there will be derangements in the physiological process. So we need to just support that whatever deranged physiological process and make it normal. That is what our aim, which will bring the very good outcomes in children. And there will be cascade of events before cardiac arrest happens. And if we stop these cascade of events, many a times we can revert back these events. Thus, we can see here. For example, if the child is have some infections, or child had trauma, or child has consumed some poisons, or some presented with a congenital metabolic problems, or child had some congenital heart disease. So whenever these kind of things comes, there is a physiological impairment will happen generally, that either leads to respiratory problem or circulatory problem or neurological problem, which if not corrected at the right time, eventually lead to the cardiac arrest. So in a sick children, the time is very premium. The time they present and the initial few hours are the golden hours when we approach structurally at the right time, and when we intervene at the correct intervention when we do, many a times these sick children will come out to have a good outcome. So that's why there is a structured, objective and systematic approach is required, where we can evaluate, identify, intervene. And there will be steps of evaluation. I need to say that a very senior physician or a experienced doctor or pediatrician can diagnose many cases just looking at the child. Same thing may not happen with the residents who are newly joined. So for them, we need to have a structured evaluation so that they will not miss any of the sick cases. So for that, there are some steps of evaluation which we can apply. They are the initial impression, primary assessment, secondary assessment, diagnostic test. So in this structure format only, if you go, we are not going to miss any cases. So let us have some videos I'll just show so that we can proceed our talk. And here is a 6-year boy who presented to us a few months back. Just you can see him. He's a little agitated. You can see there is a lot of retractions are there. So that's the thing, and you can see. Okay, and I'll just show one more video. Whereas if you just look at this child, yeah. So there are two children who are presented, and if this kind of cases comes, how we can approach? Let's go ahead. Okay, so there is something called as PAT assessment, pediatric assessment triangle. That is what initial impression. It is a just doorway assessment or hands-off assessment. No need to examine anything. Just looking at the child, what can be, we can give an impression. It's a visual and auditory impression of how sick child is. It takes very few seconds, just 2 to 3 seconds it takes. We can just do initial impression. And this initial impression has this called as pediatric assessment triangle, where we see the appearance of the child, where we see the work of breathing of the child, and we see the color or circulation of the to the skin, A, B, C. So in the appearance, we see whether child is, how is the tone of the child, whether child is responsive, whether the child is interacting, or it is unresponsive, or whether it is a consolable, or child is having a proper look or not, or a child is not having a proper gaze, and whether he is able to speak or not. these things we can make out by looking at the child, that is appearance. As you saw in the previous video, the first video, the child was responsive, he was conscious, but he had some distress. So the second child, what you saw, child was unconscious and he was unresponsive. So the thing is, the appearance will tell that there is any abnormality in any of these parameters point towards a brain dysfunction. It could be primary or it could be secondary to hypoxia. And second thing which we are assessing in the initial assessment is breathing. Just looking at the child and just see how it is breathing, whether it is breathing at all or not. Sometimes many children, they will come to ER, they will not be breathing at all. Many times broad dead children will be like that. So no breathing at all. So that is, just see whether child is breathing at all or not. If at all breathing, whether just see whether there is a bradypnea or tachypnea. And just in case you can hear stridor, wheeze or gurgling if it is associated with any pathology. Suppose a child with acute respiratory infection with wheeze, he will present sometimes, if it is severe, it can present with the audible wheeze. A child with adenoids or severe diphtheria can present with a stridor. So those things we can hear without any stethoscope. So that thing we can able to make out in the breathing. And just see whether child is breathing regularly or he is breathing asynchronous or paradoxical breathing. And any use of accessory muscles of respiration, flaring of Alainese, head bobbing, these things also can be seen just by looking at the child. So abnormality in any of these parameters points towards a primary respiratory dysfunction. Now looking at the color of the child. So see whether child is having paleness or whether child has any bruises or ecchymosis and bleeding diathesis. And see whether child is having any mottling or dusky, which suggests there's a vasomotor instability. And sometimes very sick children can present even with a cyanosis. And see for any evidence of active bleed. So abnormality in any of these parameters are a pointer towards a primary circulatory dysfunction. I'll just tell one example. If a child is having mottling or dusky, so child will have severe hypotension, which might lead to this mottling and dusky appearance, which has to be intervened as early as possible. So abnormality in any of the above parameters is a cause for immediate concern. We should alert the team and must proceed accordingly. So three things in the initial impression. One is appearance, breathing, and color or circulation to the skin, A, B, C. So when we see there's a structured approach to algorithm, suppose in the initial impression, if we find that child is unresponsive, child is not at all breathing, and child is not having any pulse, then immediately we should go for the CPR. And if the child is having pulse but the airway is not maintained, just you have to maintain the airway. So just see here, the child is conscious, normal breathing, normal color. Just proceed for primary assessment. That we are going to see what is next. If the child is unresponsive, not breathing, no pulse at all, then immediately we have to start CPR. If the child is unresponsive, no breathing or gasping, but pulse is there, then we have to just open the airway and we have to do rescue breathing. So intervention after this pediatric assessment triangle, that is initial impression, what can be done? So what we need to do is we should find out whether it is a life-threatening situation or not. Then we should call for help. A lone person cannot manage a sick case. Always you should call for the help. Then if the help comes, if the 2-3 people come, assign the roles for the team members. One person should take care of the airway and one person should take care of the putting the lines and connecting the monitors. Another person should ask the history, and any other person should, if at all required, he should be ready for the defibrillation. So attach the monitors if required. AED also can be done, and check for the pulse. If the pulse is less than 60 and we need to start CPR, more than 60, we need to support bag and mask ventilation. The first one very important thing in a sick child, what we can do is initiation of oxygen for every sick child is the simplest and most important intervention. Better is to give a high flow oxygen, which can be provided by non-rebreathing mask. And now we'll go for the primary assessment. Before going for the primary assessment, I'll just tell about few things about primary assessment. It's nothing but a rapid cardiopulmonary and brain assessment. it is hands-on examination of the child. We need to put hands on the child and we need to assess. Then only we can delineate the all things. So to identify objectively the severity of and type of physiological insufficiency, and there are 5 components. Let us see what are these. Before that, we'll just see some videos. This child presented us 4 months back. Okay. Now I'll go to one more video. Okay. So let us move on. And we'll just keep this videos in mind and we'll proceed. So any sick child comes, so initial impression we have done. After that, we identified whether it's a sick child or non-sick child. If it is sick child, we are intervening there itself with the first thing is oxygen. And if it is heart rate is less than 60, CPR. So once it is done, once settled, then we have to go for the further primary assessment. This primary assessment is done by this Pentagon assessment, which has 5 components, mainly the airway and breathing, circulation part, disability, and exposure. Let us have a brief about each one. Airway, normally what is there, like in conscious state, the normal tone is maintain the airway patency. So whenever a child takes breathe in and out, there will not be any noisy breathing. In the disease states, suppose there is an airway obstruction or there is an altered level of consciousness, what happens is the airway, there will be obstruction, so the flow becomes turbulent. So that will produce sound or noise during the breathing. So you can see here, the child is neck is actually short. Child's neck will be usually short, and you can see the child is given anesthesia, so the tongue has fallen back. So the airflow, which should be normally, it should be regular, fluent. It's a turbulent flow, which will produce the sound. So evaluation of airway is done. So we have to look for the secretions, we have to look for the vomiters or any foreign body in the airway, and listen for noisy breathing. So what we need to identify is whether there's an open airway. In that case, we have to clear and unobstructed. And if it is maintainable, so we have to maintain by the simple measures. We'll just tell what are the simple measures. And if it is not maintainable, then it needs advanced measure in the form of endotracheal intubation. You can see here, the first picture, you can see there is one shoulder roll and there is one headrest. And the thing is that external auditory meatus and sternonotch plane should come in the same line so that the airway patency is well maintained and the turbulent flow can be minimized. So that is about airway. So thing is airway, if it is obstructed, so we need to relieve obstruction only by these simple measures called as head tilt, chin lift. So that is called a sniffing position, dog sniff position, which will clear the airway. And if we go to the next component, that is breathing. So it has 5 components. In that, if we are seeing at the breathing part, we have five things. One is respiratory rate. We need to see for the work of breathing, chest wall movements and tidal volume. Tidal volume nothing but chest expansion. And we need to auscultate the child, see air entry and added sounds, and SPO. Respiratory rate, of course, we see whether child is having tachypnea or child is having sometimes bradypnea. Sometimes even child will have apnea in a case like a severe traumatic brain injury, and sometimes obstructive apnea can be there. Sometimes it can be both. So the respiratory rate we need to see, and of course we have a age appropriate respiratory rates. In an infant, we take more than 60 is a tachypnea. In a child, more than 50 will take tachypnea, and in adolescents we take more than 35 to 40 we take tachypnea. So age appropriate rates will be there. According to that, we need to see whether child is having tachypnea or bradypnea. Then we need to see for the effort or work of breathing, whether child is having increased effort for the breathing, and in the form of nasal flaring, subcostal retractions, intercostal retractions, even sometimes grunting, head bobbing, seesaw respiration. In the previous video, what you saw is the second video showed the child was having grunting. So child was grunting. and it might be having some respiratory problem. So the last thing is most important. So that is SpO2 monitoring, which is done by connecting the child to the monitor. So in this case, in this ABC breathing pattern, if you find any respiratory insufficiency, it could be either upper airway obstruction, or it could be lower airway obstruction, or it could be lung parenchymal disease, or disorder controlled of breathing. In this form only, all this respiratory insufficiency can be grouped. A simple example is upper airway obstruction in case of severe diphtheria. Child present with the severe diphtheria and upper airway obstruction will be there, where child will be fighting for the breath, child will have stridor, and increased work of breathing will be there in the form of suprasternal retractions. And one more example to say is a lung parenchymal disease, which we saw in the second video. Child had grunting and tachypnea, increased work of breathing was there. So that will tell it could be parenchymal disease. And if you go to circulation parts, again, there are 5 components in the circulation. They are heart rate and rhythm, central and peripheral pulses, capillary refill time, skin color and temperature, blood pressure. So we need to connect a child to the cardiac monitor, which will help to assess the rate and rhythm of the sick child. We need to identify whether tachycardia is there or bradycardia is there. Then we need to see whether rhythm is normal or it is fast or slow. And we need to see the QRS complexes, whether they are normal or narrow, wide complex. And of course, we know that these are the magic figures which we should keep in mind. Heart rate less than 60 per minute is a bradycardia. And in infant, more than 220 is considered tachyarrhythmia. In a child, more than 180 is tachyarrhythmia. These 180 and 220 are the magic figures we should remember. Up to 220 in an infant is tachycardia, appropriate for the clinical condition. Up to 120 in a child is tachycardia, appropriate for the clinical condition. So in a child, up to 180, in an infant, up to 220. And the next thing, what we see is the capillary refill time. Capillary circulation under the nail bed or skin is evaluated by assessing capillary refill time. Normal CRT, we know it is less than 2 to 3 seconds. Prolonged CRT, it tells circulatory insufficiency. Dependent parts, the extremity must be elevated above the level of the heart. So in cold environment, CRT may be falsely prolonged. Skin color and temperature, of course, we need to see determined by the adequacy of circulation. A good capillary circulation, it will have a healthy pink color, which is appreciable over the face, over the earlobes, palms and soles, oral mucosa and conjunctival mucosa. And if it is pale, it could be due to anemia or poor circulation. Sometimes it could be ashen gray, mottled or cyanosis, which suggests ineffective circulation. In the first picture, you can see there is a mottling, which has happened all over the lower limbs. And the second picture, you can see there's a peripheral cyanosis. Third one is a normal baby, which is having a normal pink color. Of course, blood pressure is one of the most important parameter, which many of the times residents will forget to see the blood pressure. It has to be compulsorily seen, which will tell many things. It is measured by sphygmomanometer or non-invasive oscillometric method. And the most important thing, what happens in pediatric in many centers, they will not have a proper appropriate cuff size, which is a challenging thing. So the thing is, the length of that cuff size should be 80. It should cover 80 to 100% of the mid upper arm circumference, and width should be covered 40% of the mid upper arm circumference. So which is a very good important surrogate marker for the cardiac output. And based on the blood pressure, we'll classify whether it's a shock. If the child present with the shock, we'll classify whether it is a compensated shock or hypotensive shock. And one thing we need to remember is hypotension cutoff as per the age. In the term neonate, less than 60 is considered as hypotension. Up to 1 year, 70, less than 70. And again, in the 1 to 10 years, we have formula 70 plus age in years into 2, and 10 years less than 90 we consider as hypotension. So based on the severity, again, we will classify whether it's a compensated shock or hypotensive shock. Based on the underlying etiology, we'll classify, again, it's based on the hypovolemic shock, distributive shock, cardiogenic shock, obstructive shock. I think this will, to define this, we need to have a secondary assessment, then only we'll come to know what exactly is the cause for this shock. Disability, it assesses the third vital organ, the brain. So we saw first thing is airway we saw, breathing we saw, circulation we saw. The fourth is disability. It assesses the third vital organ, brain. The brain may be involved either due to direct insult or secondary to hypoxia, poor perfusion. we need to rule out hypoglycemia, and cortical and brainstem will be evaluated. The cortical assessment is done by GCS or AVPU scale. AVPU scale nothing but alert, response to voice, response to pain, unresponsive. And brain stem assessment will be done by pupillar response and oculocephalic eye movements. You can see the first thing is a pediatric Glasgow Coma scale. Second, pupil, of course, we need to do, and also iris movement, which will assess the brain stem. The last but not the least, exposure. We have to expose the child. If many times they will be dressed, and we have to appropriately expose and examine for the bleeds, injuries, swellings, distension, deformity, and rashes that may be hidden under the cloths. Evaluation of the core temperature has to be done because fever and hypothermia both require specific intervention. Secondary assessment, most important. Once we stabilize the things, suppose that the child is having respiratory distress, we'll settle the respiratory part. If the child is having shock, we'll correct the shock. Once all these things done, then only we should go for the secondary assessment. So the secondary assessment is done by focus history and focused examination. In the focus history, we need to ask the signs and symptoms, what has led the child to here, and what past medical history was there, any allergies were there for the child. And the last meal taken is very important because many times these children require intubation and medication, any medication received till the child reached here. And even that child brought the child here to ER. That is focus history. And focus examination requires, again, after all these primary assessments, and we have to see for the neck and lymph nodes, throat, cardiac evaluation, per-abdomen evaluation has to be done. And next, once we see the secondary assessment, many things will come to conclusion. For example, a simple example I'll give: a child with a dengue will have maybe having hepatomegaly, or it might be having a third fluid loss like ascites. So those children again needs further evaluation. And for them, diagnostic test has to be applied appropriately. And of course, blood glucose we'll be doing at the bedside. And we need to consider the hematological profile, and microbiological assays should be sent. If required, culture has to be sent. And we need to know the electrolyte values. We need to know the calcium values in a child with the seizures. And sometimes we may need to order the X-rays in case of respiratory difficulty and respiratory distress and suspected pneumonia cases. And we need to order a CT scan for suspected trauma cases and head trauma cases. And in a child with a seizures and status epilepticus, we need to order the MRI. Based on the indication, we'll order the diagnostic tests. So that's about my talk. The take-home message is, whenever a sick child comes, we need to follow the structured approach. If we follow the structured approach, we are not going to fail to diagnose any of the cases which comes to ER or PICU. And the golden hours, if you follow at the right time, if interventions are done at that point of time, so child will have good neurological outcome, and they will not have any deficits in future. That's about my talk. I want to conclude. Thank you, sir. Thank you.
Thank you very much, Dr. Prakash. It has been a very informative lecture with a lot of practical tips. Next in line is Dr. Srishal Gidganti. He's a neonatal intensivist working in the BLD Medical College as assistant professor. He has completed his MBBS from BMC Bangalore and post-graduation from University College of Medical Sciences, Delhi. It's a point to note is he's a student of our present president, immediate past president of IIP India, that is Dr. Piyush Gupta, sir. He has done fellowship in perinatal medicine from Indira Gandhi Institute of Child Health, Bangalore. Currently, he is working as assistant professor and has published 2 articles in the NICU. Over to Dr. Srishal Gidganti. He'll be presenting a talk on screening in the neonates, newborn screening.
Thank you very much, our HOD sir, for introducing me with my teacher and mentor, Dr. Piyush Gupta sir. So at the outset, I want to convey my special thanks to Karnataka State Branch IMA Women Doctors Wing for organizing this PG Pathshala. We may admit that these PG Pathshala may not be replacements for the classical classroom teaching, but they will help a lot in conceptual clarifications. So now my topic of the talk is screening of newborn. So learning objectives in this is one is introduction, then screening, universal screening or risk-based screening. So screening methods and their importance. I want to share my one personal experience here. So one of my childhood friend, she is a software engineer. She came to me along with her husband to show the baby, newborn baby, so 1 month baby. So she asked me, Srishil, you check and tell so whether the baby is perfectly normal or not. I examined the baby was perfectly fine. She asked, are there any tests to be done? I asked her to get hearing screening done, ear evaluation. So suddenly the husband, so who is not from the medical background, he felt very much offended. So he came to me and suddenly told, he pulled the baby's ear and told, so the ear is perfectly normal. What is the point in checking? So screening is the point I wanted to convey here is with this example, the screening is about detecting the disease, not about confirming the or making the diagnosis. So screening is usually done in asymptomatic babies. It is done in a large group of cases. It is less accurate, it is not conclusive, and it is less expensive. And it is not the basis for the treatment. So in summary, so screening is, it should be acceptable to the people or the population at study, and it should be affordable also. On other side, the diagnostic test, it is based on certain clinical picture, and it is on the single subject. It is more accurate because the diagnosis and treatment is based on the diagnostic test, and it is conclusive, and usually it is expensive. So screening of the newborn, screening of the newborn, because it may looks very rude to say the fetus is a parasite. The classical definition of parasite is the one who is dependent for food and shelter. So but in true sense, the fetus is completely dependent for food and shelter in the baby. So once baby comes out, so the baby will start growing. So the difference between growth and development is, growth is qualitative, quantitative term, development is a qualitative term. So this development is nothing but maturation. So the baby always grows. So we assume that the baby, the development is only for the brain, but the kidneys will grow till the age of 8 years, lungs will grow till the age of 8 years, the heart will, there will be transitional circulation. So every part, every organ system, every tissue of the body, they will grow over a period of time and they will mature. So the transition happens, the first transition starts with the baby's cry. The moment the baby cries, the fetal lungs, which are filled with fluid, they will get expanded, and the baby starts showing signs of life. The baby, so the transition happens. This transition period is the best period to screen the baby for any unidentifiable disease processes. So for that, so we have multiple screening methods in the newborn period. So these screening may be universal screening. So it is applicable for all the babies, or it may be risk factor based screening, where there are certain risk factors. That's why we do screening. Suppose the baby is on ventilator. So the baby is exposed to high levels of FiO2. Whenever the FiO2 is more than 60%, the baby is at the risk of free radical injury because of hyperoxia. So in such cases, so we'll go for ROP. So ROP cannot be universal screening because it involves a lot of technical aspect. So there are certain screening methods which are universal in nature, certain screening methods which are risk factor based. Certain screening methods, they are exclusively done in preterm babies, and certain screening methods done in preterm and term babies. Suppose, so preterm baby, so we routinely do cranial ultrasonography to detect any intraventricular hemorrhage or any sequelae of such intraventricular hemorrhage. But we don't do such screening in a term babies. So sometimes even the term babies will have preterm conditions like retinopathy of prematurity also. So in that case, the screening principle will change. So that's why at the end, it is the decision of the clinician. So as our teachers used to say, we should always treat the patient, not the report. Similarly, these guidelines are they guide us to make a decision. So at the end, it should be a case by case decision. So common screening methods. So we can screen anything, but there are certain screening methods which yield good result, and they have good treatment options. So that is also one of the basic principle of screening versus diagnosis. So common screening methods are metabolic screening, hearing screening, retinopathy of prematurity screening, red reflex screening, congenital heart disease screening, and developmental dysplasia of the hip screening. So metabolic screening. So metabolic, there are more than 500 conditions associated with errors of metabolism, and they are present by birth. So that's why they are called as inborn error of metabolism. These IEMs, they are as individually, they are very rare conditions, like phenylketonuria is very rare, Tay-Sachs disease is very, very rare. But their collective contribution to the overall mortality and morbidity in neonates and in children, it is very significant. That's why the prompt diagnosis is very much needed for the treatment, then prognostication, genetic counseling in the subsequent pregnancy. So we must understand that every pregnancy is a precious pregnancy, every newborn is a precious baby. So that's why, so earlier, these IEMs, most of them are autosomal recessive disorder. So they are undetected or undiagnosed or untreated. So because of improvement in the quality care, so screening of these metabolic conditions helps in the prompt diagnosis and the treatment. So this one concept which is very interesting in metabolic screening is tandem mass spectrometry. So this is called TMS. So this is a one of the revolutionary method in case of screening, metabolic screening. So in this is very important concept in molecular genetics, where it helps in identifying the abnormal metabolites. So here the sample is taken. So through the process of ionization, the sample is fragmented. The sample is divided into ions. So again, these MS1 precursor ions are produced. These precursor again subjected to the collision with the photons, and they are made into fragments. So this tandem mass spectrometry helps in identifying and quantifying because we need to identify the abnormal protein, we need to identify the quantity of the protein. Then only, because in case of phenylketonuria or in case of hyperammonemia, so even normal individuals have ammonia levels. But if the ammonia level is more than 250 units, then it is abnormal. So it's not only important to identify the abnormal metabolite, it's also need to quantify. So by using this simple technique, tandem mass spectrometry, so we can identify abnormal metabolites in most of the conditions. So this concept is very much important because this has revolutionized in identifying the autosomal recessive inborn error of metabolisms. So now the clinical pointers towards the IM. So when to suspect an IM? So IM babies, if my PG comes and tells me, sir, the baby became bad in the labor room itself, and the baby did not cry, and the baby was intubated and taken on the ventilator. So can we suspect IM? No. There must be some period of apparent normalcy. The baby should receive some feeds, because this is very much important. Because as I told earlier, the fetus is a completely dependent. Whatever for nutrition it is dependent, for a removal of the metabolites it is also dependent. That's why the baby has not manifested the metabolic problem. So once the baby takes feed, because of abnormality in the metabolism, the toxic metabolites will get accumulated. These toxic metabolites will start showing the symptoms and signs. This period of apparent normalcy is very much important. So it's an important clinical pointer. As I told, so there is I want to just revisit the cellular biology. The cell has nucleus. In the nucleus, there is a nucleolus. In the nucleolus, there is a chromosome. On the chromosome, there are genes. The place where the gene is present is called as loci. These genes codes proteins through codons. So whatever I have now, so one allele I have received from the father, another allele I received from the mother. So in case of autosomal recessive, so autosomal recessive conditions manifest only in the presence of homozygous condition. So that's why if the parental consanguinity is there, the parents may be carriers both, but there is a 25% chance that the homozygous condition will be there. So that's why for to suspect an IM, there will be a parental consanguinity. So history of unexplained neonatal deaths. As I told, the inborn error of metabolism, it is a still evolving subject. The topic is like ocean. So the knowledge what we have at present is very much limited. So the previous neonate may be undiagnosed, undetected, untreated, and the baby has died. So that's why unexplained neonatal death in the family is very much important. Similarly, seizures of unexplained cause. So neonates have a very low seizure threshold. So they will throw convulsions very easily, but most of the time the cause will be identified. So whether it is because of hypoxia or hypoglycemia or hypocalcemia or hypomagnesemia. So we know that these are the common causes. So common causes are always common. The thing, the cause which is unexplained, so that may point towards IM, like folic acid deficiency or biotinase deficiency. So other IM conditions. And if the baby is having persistent vomiting, so persistent vomiting, so we always think about surgical abdomen. But IM is one condition where there is a persistent vomiting and it's a medical condition, and peculiar urine odor. So what is the appropriate time for collection of these samples? As I told, there should be adequate amount of toxic metabolites or abnormal metabolites. Then only the baby will have the testing will be productive. Otherwise, if we keep the baby NPO and we do testing, the reports will be normal. We start the feed and again the baby becomes sick. Again, we keep the baby NPO. This is called hide and seek in IM. So once we start feed, the baby will become symptomatic. Once we keep the baby NPO, the baby will become asymptomatic. That's why the baby should have adequate amount of abnormal metabolites in the blood. Then that's why the collection of samples should be done after 30. So there are n number of not n number. There are more than 500 IM conditions. They are broadly classified as amino acidopathy, fatty acid oxidation deficiency, organic acidemia, in again like phenylketonuria, maple syrup urine disease, homocystinuria, or citrullinemia, or tyrosinemia, glutaric aciduria, propinic acidemia, and like. So this screening for metabolic screening, it is limited screening or extended. What is limited screening? We identify only 3 conditions. The common, there is a dictum in medical science. Uncommon manifestation of common diseases are common than common manifestation of uncommon diseases. Tay-Sachs disease is very much common in Jewish population. So it is not that common in case of in our population. If we go on screening for Tay-Sachs disease, the yield will be very, very less. But congenital hypothyroidism is very common in our population. So in case of limited, we choose and pick 3 conditions or 5 conditions or 7 conditions. So that is limited newborn metabolic screening. In case of extended, based on the family history, based on other parameters, we extend the spectrum. So one of the condition, congenital hypothyroidism. Congenital hypothyroidism is very important condition because it is preventable cause of intellectual disability in the children. So the incidence of congenital hypothyroidism is 1 out of 4,000 live births. So congenital hypothyroidism, almost 80 to 85% of the cases have thyroid dysgenesis or disharmoniogenesis. So the treatment for the congenital hypothyroidism is simple, effective, and it's almost curable because just it is thyroxine replacement is the cure. So if we give thyroxine at the very early age, so thyroxine is very much important, not only for the postnatal brain growth, even for the intranatal fetal brain growth. So that's why for the first 3 years of age, the thyroxine hormone is very much important for the overall development of the baby. That's why congenital hypothyroid babies will be short, they'll manifest as short statured. So if we provide thyroxine replacement at an appropriate times, as early as within first month, that is in the neonatal period itself, so the baby will be almost like a normal baby. So how do we screening? So cord blood TSH level, there was so much controversy during our PG preparation in 2009 to 10. So whether to do cord blood sampling or not. So nowadays cord blood TSH levels are not done routinely, but they are done if mother is having any hypothyroid or if the other sibling is hypothyroid. Then only we take the cord blood TSH. Otherwise, the enthusiastic cord blood TSH evaluation leads to or diagnosis of the congenital hypothyroidism. In other babies, we do on day 3 or day 5. So we go for the levels. If the level is less than 8 or 10, so no further action is needed. If it is more than 25, so the chances of congenital hypothyroidism are very high. So we need to refer the baby to endocrinologist, or we get the sample and we need to start the thyroxine treatment immediately. If the level is 8 to 24, then we need to repeat the test after 1 to 2 weeks. So if the again levels is less than 8, so no further action is required. If the level is more than 10 or more than 8, so we need to start the thyroxine supplements. So there are 2 approaches in congenital hypothyroid newborn screening. One is first we'll do TSH, then we'll go for T4. Second approach is one will go for T4, then we'll go for TSH. The third approach is TSH plus T4. In case of first TSH, so we may miss out the central hypothyroid causes. So because the pituitary or hypothalamus, if it is defective, the TSH will be low. The low TSH will give a false impression that there is no hypothyroidism. In case of T4, if the T4 is in the second approach, so subclinical conditions we may miss out. The third approach is the best approach, but it's a screening method. So whenever we talk about screening, it should be acceptable to the society. It should be affordable. So TSH plus T4 is not cost-effective method. So next topic, next subtopic is hearing screening. So we all know if the now I am talking. So this is my speech. So this is an output. So this output has a processing called brain. This brain as a processor, it requires input through my hearing. So that's why hearing is very much important for the child for the child development. So the ear has 3 components. One is outer ear, another one is middle ear, third one is inner ear or sensory ear. So there are different types of hearing losses. Hearing loss. One is conductive hearing loss, second one is sensory hearing loss, third one is sensory dyssynchrony. So this is all about hearing loss, but the incidence of hearing loss in a healthy baby is 1 out of 1,000 babies. So, but in a case of high risk babies, the incidence is 40 out of 1,000 babies. So these hearing losses, so here one rule is there, 1, 3, 6. So before the first month, so we should screen the baby. Before 3 months, we should make a definite diagnosis. Before 6 months, we should start intervening in the baby's hearing. So if we start a proper hearing, then the baby will receive proper input. Then the brain will process the information that will help in producing the good output through basic, especially in language and communications. So for screening, we have two methods. One is OE and one is BERA. OE is otoacoustic emission. Second one is BERA, means brain stemmed evoked response audiometry. So in case of otoacoustic emission, the outer hair cells, they have a property to generate an acoustic sound. So whenever a sound is given in the external ear, this sound will traverse through the external canal, then through the middle ear, through the ossicles, then it will reach the auditory hair cells, outer hair cells. They produce a sound. This sound is again detected in the machine. So this machine will help us. If there is any conductive hearing loss, that sound is not reported back to the instrument. So the OE report will be either pass or referred. So if there is a OE pass, so the hearing is almost normal. If there is a refer, so we need to repeat the OE on 2 occasions, 2 weeks apart. So again, it is referred, then we should go for the BERA, because BERA is a technician dependent and it is very cumbersome procedure. But OE is very easy to do and very fast process that is very much suited for the screening modality. So in case of BERA, so BERA has 2 applications. One as a screening BERA, second one as a diagnostic BERA. In case of screening BERA, we go for one frequency, that is 35 decibel. So then we go for the, what is BERA? BERA is nothing but it is the study of the, it's the easy produced due to the sound. So as the sound travels, so it will produce the electrical discharges. So these electrical discharges are picked up from the instrument and they'll be represented in a graphical manner. So there are different waves, wave 1 to wave 7. So from the different points of the auditory nerve. So these nerves will produce the electrical discharges. These electrical discharges are picked up from the machine in the form of wave. So in this, we'll study mainly. So most of the waves, this is a very textbook diagram, but most of the BERA, the report won't be like this. So we mainly aim for wave 1 and wave 5. So if both are present, that means so the BERA has passed. So if the screening BERA has failed, then we'll go for the diagnostic BERA. So in case of diagnostic BERA, we'll go for individual frequencies and we'll make a diagnosis where exactly the sensory neural hearing loss is. So next subtopic is ROP screening. What is ROP? ROP is retinopathy of prematurity. What is retinopathy of prematurity? So it is a vasoproliferative disorder of the retina in a premature baby. So it's not always a premature baby, it's a premature retina. So even sometimes we do see so ROP in cases of term babies also. So this ROP, there are certain terminology we should know. So one is the retina is classified into zones. These zones are very much important because as I told earlier, everything gets matured. So maturity is nothing but acquisition of the skills. So retina has to perform certain functions. So for that, the avascular retina should become vascular retina should become avascular retina. If vascular retina becomes avascular retina, this is perfectly normal retina and it will do its functions. Because of some adverse events or some insults, because of this, so there will be some amount of injury to the retina. So this injury results to vasoproliferative disorder. So that's why, so this optic nerve is very much important because from this area, the retinal artery starts and the vascularization starts here. So that's why zone 1. So zone 1 is a concentric ring with a diameter of double of the distance between the optic nerve and the macula. So zone 2 is again, it's a concentric ring with the optic nerve at the center. On medial side, it will touch the nasal serrata on nasal serrata. The remaining portion is called as zone 3. So ROP is done, staging is done. There are 5 stages. So 5 stages. Stage 1, it is the demarcation line between the vascular and avascular retina. Then stage 2 is there is a ridge between the that line becomes a ridge because so that vascularity increases. Then that vascularity becomes fibrovascular tissue. Then in stage 4, there is a partial retinal detachment, and stage 5, there is a complete retinal detachment. So with this ROP background, there is something called as a screening window, because as I told, there is a timing for everything. So we can't do metabolic screening in on the day 1. Or if the baby becomes a very sick baby and day 1 only, we can't suspect IM condition. Similarly, we hardly see any ROP before 32 weeks of gestation, because there is a transition from the vascular retina to the avascular retina. So that is a normal finding in a 32-weeker baby. So we may miss out. And ROP usually does not develop before the first 2 weeks of postnatal age. Whom to screen? So any baby less than 1.8 kg baby, so they are at the risk of ROP. Gestational age less than 34 weeks. Any high-risk newborn baby with significant stay in the NICU. So these babies are the candidates for the ROP screening. So next important red reflex screening. So in this, we do shed the ophthalmoscopic light over the retina. So it should show a reddish orange reflection. So that is a normal reflection from the vascular retina. So if it is not there, then suppose conditions like congenital cataract, congenital glaucoma, or congenital leukocoria, suggestive of retinoblastoma. So it will be a white reflex. So this is a very simple, easily doable. So red reflex screening. Next subtopic is congenital heart disease screening. The incidence of congenital heart diseases is 6 out of 1,000 live births. As a student, we have studied the classification of congenital heart diseases as mild, moderate, severe, and critical. So critical means if we don't intervene at the earliest, the baby will collapse and die. So mainly because of hypotension. So there are certain conditions which are duct dependent. So one of the condition is coarctation of aorta. So in case of coarctation of aorta, if you don't intervene, so the baby will suffer from the hypotension and baby will collapse and die. That's why prompt recognition and early initiation of the treatment will be life-saving. So there is a pulse oximeter based screening for the critical congenital heart disease. This is very nowadays the NRP advocates the routine usage of the pulse oximeter. So pulse oximeter is used to screen the congenital heart diseases. So it is very simple. So we should check in the right hand or any foot, right or left foot, because in case the left hand, in case of 10%, there may be preductal PDA. So because of that, there may be the saturation may not reflect. So the right hand is always chosen because the right hand reflects the saturation of the brain. So that's why the right hand and the left hand. So we will have the difference preductal and postductal. If the right hand saturation or the foot is more than 95, or if the difference is less than 3%, so then the test has passed. If the saturation is less than 90%, the test has failed and the patient should be referred for the echocardiography. So suppose if the saturation is 90 to 95, then you repeat, or if the difference is more than 4%, you repeat it after 1 hour. So again, if it is less than 90, it has failed. If it is more than 95, it has passed. So again, you do it after 1 hour. So again, So it in a nutshell, pulse oximeter more than 95% pass, less than 90% failed. It is if it is in between 90 to 95%, repeat 2 times 1 hour apart. Then you go for the echo. So echo will tell us what specific congenital heart disease the baby has. Then an important bedside we can do even in the labor room. So one of the textbook has mentioned every pediatrician who attends the call should always go for the femoral pulse evaluation, because it's a now at present we in NICU we have a coarctation of aorta baby, so it is very mild form, but the baby femoral pulse is very much feeble. So we took the opinion of the cardiologist. So the baby is hemodynamically stable. So stepwise we'll go for the further management. If the femoral pulses are feeble, then we should think about these critical babies: hypoplastic left heart syndrome, aortic stenosis, or interrupted aortic arch, or coarctation of aorta. So by doing simple femoral pulse screening, so we can detect these conditions. Next is very much important is cranial ultrasonography screening. This is done in preterm babies, that is less than 32 weeks, less than 1.5 kg babies, mainly to rule out the IVH babies or any parenchymal injured babies. There is an interesting topic in the textbook of Cloharty, where there are certain ethical dilemmas, whether we should continue the care of the baby or not, to go ahead, not to continue. Because in the crux of that chapter, it has been written that if there is a significant morbidity with respect to that baby, so it will be a burden, emotional burden for the parents. At the end, we all as a doctors, we agree the parent decision is the final decision, but we should be able to make them understand the situation so that we should have it. We should do the neurosonography, neurosonogram, so that we can assess. Because if there is a grade 4 IVH or grade 3 IVH, so the chances of baby survival are very less, or the chances of this baby becoming cerebral palsy are very, very high. If this information is given to the parents, and they should, if they make a, they'll make a well-informed decision. So that's why routine cranial ultrasonography screening is done in case of preterm babies. So what is the time schedule? First scan, it should be done in the first 72 hours, usually 1 to 3rd day, because most of the IVH, almost 85 to 90% of the IVH happen by day 3, 99% IVH happen by day 7. So second screening done end of the first week. So that time also the early PVL changes will start happening. Third scan, first month, cystic PVL changes will happen. Can be seen. Fourth scan, so corrected gestational age for the term. So here we will see the PVL sequelae, periventricular leukomalacia sequelae, that is ventriculomegaly and hydrocephalus. So cranial ultrasonography in case of preterm has a lot of importance in case of counseling, so that also prognostication. So this is last one, DDH, developmental dysplasia of the hip screening. So as students, MBBS students are preparing for the PG, so we used to have DDH, or congenital dislocation of the hip, or developmental dysplasia of the hip screening. But there are many studies. These studies done for universal as a universal screening method or risk factor based screening method by using clinical methods, classical Barlow test or Ottolani test, or through ultrasound. They have detected developmental dysplasia of the hip, but that has led to the O treatment. The negative aspect of this O treatment led to the avascular necrosis of head of the femur. So I wanted to, I added this slide because the screening in newborn. So there is a concept, newborn screening, NBS, that most of us always think that it is metabolic screening. So screening of newborn is for the different systems. So this developmental of dysplasia of the hip screening, it is discontinued these days. So I conclude my talk. So I do understand this topic is not a straightforward exam question like PPHN or RDS or meconium aspiration syndrome. But if the examiner wants to check the overall knowledge of the neonatology, so the topic he can give this type of question like screening in case of screening methods in newborns. So I try to cover the topic through. Thank you very much. I conclude my topic.
I request Dr. Kalyan Shetty sir to kindly give opening remarks for this.
Thank you, ma'am. Thank you, Dr. Srisham, for a detailed discussion on screening in the neonates. That was a very informative talk. And I would like to thank the office bearers of IMA KSB and Manpreet ma'am in particular for giving us the opportunity to present these topics in the PG Pathshala. Thank you, everyone.
Thank you very much. Sir, and now before we go to the vote of thanks, can I request Dr. Srinivas sir to kindly say a few words for this, because his would be the expert comments on the topics along with Dr. Kalyan Shetty sir. Dr. Srinivas sir? Okay, I think he is not there. I request Dr. Anuradha Parmesh madam, a very dynamic and a very, very active member of IMA KSB, to kindly propose the vote of thanks. Over to you, madam.
Yeah. Good evening, everybody. Happy Mahashivratri festival celebration. In spite of our preparation for the festival tomorrow, we have got adequate number of our doctors who have logged in, who are very academic, lovers like me. So very sincere thanks to our IMA KSP President, Dr. Shukumar Lakol, our Secretary, Dr. Karunakaran, and our Chairperson, WDW Subcommittee Chairperson, Dr. Manpreet Kaur, for having organized such wonderful topics for us. They're all hot topics which all of us need to know, particularly the practicing obstetricians. We need to know some basics about neonates and pediatrics, because once you deliver the babies, the mothers tend to get back to you to take your suggestion and feedback. So we need to be in a position to let them know what exactly they need to do. Particularly for us, the last topic is very, very important. And sincere thanks to Chairperson Dr. Kalyan Shetty, as well as to our speakers, Dr. Kulkarni, Dr. J. Prakash, as well as Dr. Sri Shail. And last but not the least, to all the doctors who have logged in and made this session very successful. And I look forward to listening to more and more hot topics like that through webinars like this. Thank you one and all for a patient hearing.
Thank you. Thank you, madam. Thank you, everyone. I think we'll leave the meeting now. Thank you, everyone. Thank you, sir. Kalyan Shetty. If there is time, I would like to complete what I started. But in the beginning, as an obstetrician, when one of my babies used to go to the NICU, I really used to be worried, when they are going to come back and other things, because we are scared of nosocomial infections and all. But once I started going to Dr. Kalyan Shetty sir, then I used to be, very assured that no unnecessary treatment, no delays in getting the baby out of the NICU would be there. And, my number of calls to Dr. Kalyan Shetty sir slowly decreased over time, because otherwise I used to bother him 3 or 4 times a day, sir, when is the baby coming back? But later on, I was so reassured of the, the correct treatment and the judicious treatment to the babies, that I knew that, sir, when he feels the baby is okay to be out, he would send the baby out and I won't really have to bother. So this is just a memory that of since 20 years that I wanted to share. So thank you very much. And thank you so much, ma'am, for this vote of thanks. Thank you. Thank you, John.
Thank you, ma'am. Thank you for your kind words.
Thank you, sir.